Hello everybody, and thank you for joining me in this new short video presentation from ECG Exercises. I hope you will enjoy this video. If you are new to my channel, please do not forget to subscribe. Let's go directly to the introduction. Our patient today is a 62-year-old man, known case of coronary artery disease, old inferior wall myocardial infarction, ejection fraction of 31%, who was admitted to another hospital because of recurrent ventricular tachycardia and ICD shocks. The patient underwent catheter ablation, endocardial catheter ablation, and at the end of the procedure, one ventricular tachycardia remained inducible, and they suggested that the exit of the VT might be epicardial, so they transferred the patient to our center for epicardial catheter ablation. Here we see the ECG with during CRT stimulation. Very important point. We also have to look at the ECG morphology without CRT stimulation. And here we have the sinus rhythm without CRT stimulation, long PR interval, and left bundle branch block morphology in ECG. And here we have the ventricular tachycardia, a negative concordance, which definitely shows that the wide QRS complex tachycardia is a ventricular tachycardia, and we have a left bundle branch block-like morphology. When we look to the leads, especially 2-3 AVF and the QRS duration, this may suggest an epicardial exit. But there is one important point. This is a patient with post-infarct ventricular tachycardia, and some of the ECG criteria that we use to differentiate endocardial from epicardial exit, especially some criteria in QRS morphology, are not applicable to patients with post-infarct ventricular tachycardia. An important clue to the correct diagnosis comes from comparison of ventricular tachycardia with ECG in sinus rhythm. The QRS morphology and polarity, is almost the same as in sinus rhythm, but the QRS complex during ventricular tachycardia, of course, is wider. Despite having post-infarct ventricular tachycardia, in such cases, we have to always remember bundle branch reentry as a possible diagnosis of ventricular tachycardia, although this VT is usually seen in patients with non-ischemic cardiomyopathy. Here we have the 12-lead ECG with his electrode, which shows an HV interval during sinus rhythm of almost 70 milliseconds, and finally the HV interval of 105 milliseconds, and subsequently successful simple ablation of this ventricular tachycardia confirmed the diagnosis. The patient remained stable and discharged from the hospital. So once again, thank you for joining me in this short video presentation, and I'm looking forward to have you here in my future video presentations. Once again, thank you for your attention.